السلام عليكم. هتكلم سريعا ان شاء الله. طبعا شكرا لاساتذتي الكرام وزملائي. هتكلم ان شاء الله سريعا على our unit experience with therapeutic hypothermia. Therapeutic hypothermia is the most effective neuroprotective therapy for neonatal hypoxic ischemic encephalopathy. Current evidence shows that the infants who benefit from therapeutic hypothermia are terminal late preterm infants, 36 weeks or older, with moderate to severe hypoxic ischemic encephalopathy who are 6 hours old or younger. The patient should fulfill both physiologic and neurologic criteria. Physiologic criteria, one of the following: blood gas, either a cord blood gas or within the first hour of pH less than 7 and base deficit more than 16, an acute perinatal event, plus either a 10-minute Apgar score of less than 5 or continued need for ventilation initiated at birth and continued for more than 10 minutes. The neurological criteria include the presence of seizures or physical examination consistent of moderate or severe encephalopathy according to the Sarnat score, moderate encephalopathy in the form of lethargy, decreased activity, distal flexion, hypotonia, weak reflexes, constricted pupils, bradycardia or periodic breathing, and severe encephalopathy in the form of stupor, no spontaneous activity, disparate posture, flaccidity, absent reflexes, dilated or non-reactive pupils, variable heart rate, or apnea. Our cooling device is Ticotherm, made in Germany. It's designed by 2 water reservoirs that operate by pumping cold and warm sterile water into a mattress. After decreasing the infant core temperature to 33.5, feedback for temperature regulation is provided by the mattress temperature sensor. Once the cooling therapy is complete, the system again rewarms the water inside the mattress and gradually increases the neonate temperature. A rectal sensor is used for continuous rectal temperature monitoring. I will demonstrate the two most recent studies at our unit. In the first study, we observed 37 patients with moderate to severe hypoxic ischemic encephalopathy fulfilling the criteria for therapeutic hypothermia. The aim was to detect complications and risk factors for mortality. Apgar scores ranged from 0 to 3 at 1 minute, 0 to 6 at 5 minutes, and 1 to 8 at 10 minutes. Complications were detected in the form of hypotension, bradycardia, prolonged QT interval, and coagulopathy. Bradycardia, hypotension, and coagulopathy were associated with increased risk of mortality. Severity of hypoxic ischemic encephalopathy was associated with increased risk of mortality. No association between mortality and onset or duration of therapeutic hypothermia. In the second study, we observed 41 infants with moderate to severe encephalopathy who underwent therapeutic hypothermia and assessed their neurodevelopmental outcomes at 3 and 6 months of age. Some neonates in this study underwent active cooling, while the others underwent passive cooling when there was a technical problem in the machine. Passive cooling was done by switching off any active warming devices and opening the portholes of the incubator with measuring rectal temperature every 30 minutes. Neurodevelopmental assessment using Bailey scale of infant development and 3 and 6 months of age was done. We used Bailey 3, which is the latest version of Bailey scales of infant development. It's the most widely used developmental tools in both clinical practice and research settings for assessment of development in infant and child up to 42 months of age. Apgar scores ranged from 0 to 3 at 1 minute, from 0 to 5 at 5 minutes, and from 1 to 5 at 10 minutes. 10 units underwent passive cooling and 31 underwent active cooling. When we compared both types of cooling, we found no statistically significant difference between them regarding Sarnat staging post-cooling, hypoxic ischemic changes in cranial ultrasounds, complications, or duration of survival. When comparing the developmental outcomes, the language score at 3 months and the motor scores at 6 months were significantly higher in the active cooling group. When we compared survivals and non-survivals, we found no statistically significant difference between them regarding neonatal baseline characteristics or blood gas parameters. The non-survivals had significantly higher percentage of hypoxic changes detected by cranial ultrasound and significantly lower Apgar scores at 5 minutes of age. Neonates who received early cooling in the first 1 or 2 hours after birth had significantly higher survival rate. The Sarnat stage was worse both before and after cooling in non-survivals. However, these differences were not statistically significant. Neonates receiving longer cooling had a slightly higher survival rate with no statistically significant difference. The Bailey scores of survival were not statistically significant affected by the onset of cooling, but neonates who underwent longer duration of cooling had significantly better Sarnat staging after cooling. The motor scores of neonates receiving longer cooling were significantly lower at 6 months compared with the other group. Regarding the developmental scores, the cognitive, language, and motor scores at 3 months of age was significantly lower than in 6 months of age. This indicates an improvement in the neurodevelopment of those infants at 6 months of age. Regarding the relation between the Bayley scores and the brain MRI, the developmental scores were lower in patients who had hypoxic changes on MRI, but was no statistically significant difference except for the cognitive score, which was significantly lower at 3 months of age in patients who had hypoxic changes on brain MRI. So from our experience, we can conclude that the earlier the therapeutic hypothermia, the better the survival rate. Patients with lower Apgar scores at 5 minutes and hypoxic changes on ultrasound had an increased risk for mortality. There was no difference between passive and active cooling regarding incidence of convulsions or complications. Active cooling was associated with better language and motor scores. Hypoxic changes on MRI were associated with low cognitive scores at 3 months of age. The cognitive, language, motors, and motor scores were significantly higher at 6 months compared with 3 months of age. And thank you.
المدرس الممتاز بتاعنا في الانكلوجن كرايتيريا
يعني هي الاريا بتحدد 6 اورز اللي حضرتك قلتيهم دول الحقيقه كلينيكالي في النيوناتولوجي متهمين قوي يعني حضرتك حتى قلتيها في الباثولوجي هي بعد 6 اورز الحقيقه الانترفنشن خلاص